Hello and welcome back to In the Gray Area with REVV Health. I'm Brittany.
And I'm Travin, and today we're going to talk about lab work. And this is just kind of like an impromptu one that we decided we needed to do because we've been getting a lot of questions, it seems like lately in particular, of people focusing, in our opinion, way too much on certain lab parameters. And so we just kind of want to go over with everyone, like, what are the main things that we like to pay attention to? What are some of the lab markers that maybe we don't put as much emphasis on? Just kind of give everyone a good idea, since we seem to get these questions a lot. So we thought we'd have Lisa stick around and help give her perspective on this one as well. So good to have you back, Lisa. So I think I'll just start with the big one, which is testosterone, because that seems to be the one that we get a lot of kickback on. And it seems to be the one that most people, especially guys, are the most focused on. And it's like, in reality, it's probably one of the ones that is least relevant when you're on therapy. You know, it's good when you start out, we can get a baseline and see where you're at. But in terms of like when someone starts testosterone, yeah, we know it's going to be high. We know it's probably going to be over the range or at the top of the range. And so it's kind of like, we're not really as concerned with that number is. We're more concerned with, has your symptoms improved and how are you feeling?
Yeah, and what's interesting with testosterone is people, when it gets outside that range, they start calling it super physiologic levels of testosterone. And actually, though, like 50 years ago, 1500 was the normal range. So why is it now that we're saying that 1,000 is super physiologic? Yeah. So, it's interesting to look at how they come up with the testosterone ranges. And it's not like your other labs where we're looking at symptoms that you'll have these symptoms if you're low and you'll have these symptoms if you're high. That's not how they determine testosterone levels. They just test a group of men in a certain age group, and that's what the range is. There is no like studies or clinical evidence that says you need to stay within these parameters. And a lot of primary care physicians and nurse practitioners will decrease your dose if you get above the high range of testosterone levels.
Yeah. Which is interesting because, to like piggyback on what you said, like there is no number that correlates with everyone that correlates with symptoms. There's no number that says everyone above this won't have symptoms, everyone below it will. And on the other side, we don't have a number that shows this number's too high. Anything above it's dangerous. Anything below it's not. Like that number that doesn't exist.
Exactly.
So we don't know if there is a number, but to that point, when we're treating someone with testosterone and if we're concerned with health, like we want to look at the actual health parameters that we can quantify. What's their blood pressure? What's their hemoglobin A1C? What are their lipids and lipoproteins doing? Like what's their waist circumference? And all of these things that we see every single one of them improve on testosterone therapy. And so that's what these providers should be focusing on rather than just an arbitrary testosterone number.
Right. And it's crazy. I had a patient who went to their cardiologist and their primary care doctor, and they saw their testosterone levels and kind of flipped a lid, right? And said it was so dangerous. But they did not look at his change in his BMI, his improvement of his lipid panel, his weight loss, all of the things that have improved. They were so focused on that testosterone level. And truly, once I've started a patient on testosterone therapy and I recheck their, at 2 months, we're checking that just to make sure they're absorbing. But then from then on, especially with testosterone, I am just titrating their dose based on their symptoms, because what I might feel good on with testosterone may be completely different than what you feel good on, right, Brittany? And so we're all individuals, and these clinics that just automatically put people on a set amount and that's what you get, it's sad because everybody metabolizes hormones differently and everybody feels better at different levels, and it needs to be individualized for the patient. So
I think for women too, that's a very common question I get, especially before they start working with us, because a lot of times it's new to them to even think that they might need testosterone because they've thought it's a male sex hormone for so long. So then when they ask, they're like, okay, so my number is non-existent. What number are we trying to reach? And overcoming that even for females is really hard because there really is no deficient number for a female. And also there is no optimal. And so letting them know that, like, yes, what I feel good at, especially after like 2 years of introducing testosterone into my body, is going to look different than you, especially initially. And for men versus women, we also have where we have to go slower with the females.
Well, and it's interesting, even in nurse practitioner school, we didn't even address testosterone in women. Like, that wasn't a thing. Like, we didn't even talk about it. We had maybe part of one day on Premarin and Provera, but nothing about testosterone. So, my female patients who are coming to me with no libido, with no energy, with muscle loss, their main concern is, am I going to grow extra facial hair and look like a man? And am I going to,
Voice changes
have
and-
voice changes? And am I going to start having acne? That's their main concern. And it's like, okay, you need to refocus on what testosterone can do, and how we look at that, and that's not a thing. Like, we can.
I know. Britt, I think you should have turned into a man by now with your testosterone level.
Well, it's not as high as the lady we heard the other day in our training. So
I know.
yeah, it's crazy what we hear and stuff. But I think it's also really important for men and women just to understand that it is completely safe what we are doing. And again, it is bioidentical. And as long as we're just getting them to that point of having the symptom relief, that's what our main goal is. It's really not targeting a number.
Yeah, and with going through the WorldLink training, that was eye-opening and kind of shocking to see the levels of testosterone they were getting on women, and just in general, my WorldLink education and certification was just eye-opening and life-changing.
Yeah.
Another lab we see more often, I think, than even with testosterone with other doctors is thyroid.
Yes.
So I think we should kind of touch on that too, especially the TSH.
Yeah, I mean, I again go back to, it's kind of like the same. I look at it the same way as kind of testosterone. Like when we're treating someone's thyroid, we're optimizing T3, and when we recheck labs, of course, we know T3 is going to be elevated. We're optimizing that, but again, thyroid's one of those things where we're kind of guided by symptomatic improvement rather than trying to fit within a certain level. We know the TSH is going to be suppressed, and so that's not a surprise, but a lot of providers do find that alarming when if they're checking their patients' labs and the TSH comes back suppressed. It's usually alarm bells go off, and we're causing them to be hyperthyroid, and we're going to cause all this harm. And
well, what's crazy, in my 20 years of practice prior to starting into hormone therapy, I had patients coming in all the time with every symptom of thyroid disease. And we would check a TSH and we would check a T4 and it would come back normal. And we would say, it's not your thyroid. But they had every symptom of thyroid disease. So it's pretty wild. And, providers really get nervous when a TSH gets below 1. They get kind of freaked out about it. And I try and remind patients who are worried about that, because their provider made them worried about it, that, if we're treating somebody even with thyroid cancer, we try and get their TSH below 0. That's our goal. And all a TSH tells you is that you're getting high enough levels of thyroid and T3 that your pituitary gland is not having to send that message to the thyroid anymore. It has absolutely nothing to do with your thyroid. The TSH is all about your pituitary gland, not your thyroid. So stop worrying about the TSH. It has nothing to do with it. So, and focusing on the T4 is not very effective either, because as we know, with environmental toxins and other things that are affecting thyroid levels, it's the conversion from T4 to T3 that's the big problem. And T3 is actually the thyroid that gets into your cell and binds with oxygen and makes energy. So we need to focus on T3. T3 is your metabolism.
And it's also, we had a patient not too long ago that came in, and same thing, was freaked, or her provider freaked her out because her T3 was really high. And it turns out, she did lab work, 4 or 5 hours after she took her thyroid medication. And so I asked her, I said, okay, if you would have tested maybe later on that day, or maybe you didn't take your thyroid hormone that morning, you would have got a completely different T3 that would have, satisfied your provider. She would have been happy. Yet nothing changed with your dose. Nothing changed with the response. It was all about the timing of when you did the labs. And so kind of a light bulb went off in her head. And I'm like, so it's just completely arbitrary sometimes that people focus so much on these specific numbers without getting a bigger picture.
And I think looking at symptoms, what are your symptoms? Well, I'm feeling great. Well, if you have hyperthyroidism, too high of thyroid, you're going to have severe tachycardia where your heart is just racing, and severe anxiety. And so these patients coming to me and they're like, well, I feel great, but my doctor says that my T3 is too high. It's like, okay, so having a lot of energy and feeling great is a problem.
Yeah. Oh, yeah. Oh, and by the way, she's lost weight too. It's like, what? So what exactly is the problem? Everything.
And her metabolic syndrome went away.
Yeah. Everything you wanted to accomplish has happened, yet but you're worried about this number. It's interesting, but those are, I think testosterone and thyroid are two labs that I do think is just kind of like, we know what it's going to be. Don't put so much emphasis on it.
I think the ones that we need to focus more on, especially for like our female patients, definitely is estradiol and making sure they're in menopause before we put them on. But then also, so those labs are important in the beginning, but then also once we do put them on it, making sure that we keep that balance between the estradiol and the progesterone and that they're getting adequate amounts of progesterone.
Well, and really, our goal, and sorry to say this, but on the lab slip, their estradiol goal is way different than mine. My goal is to get people above 75. That's where you start having the cardiac benefits and the brain benefits and all of those other benefits that we're looking for. So we want them to get above 75. And it's vital that their progesterone is high enough to protect their uterus from hyperplasia and developing uterine cancer. So the progesterone has to be above 10. You cannot achieve that with topical progesterone. You just can't. So it's vitally important even for women who've had hysterectomies to be on adequate progesterone. Because if you have any endometriosis, and a lot of women have it without knowing it, if you have endometriosis and you take estradiol by itself without opposing it with adequate amounts of progesterone, you can get cancer.
That's
so
where it gets
super
dangerous.
Important.
Yes. Yeah. And we see that a lot. I mean, how many times have we seen women come in where they have pellets? I know we talk about that all the time, but it's like they'll have a pellet and it's like a pellet for testosterone, a pellet for estradiol. And then it's like, and then they're taking maybe like, 50 milligrams of progesterone.
Or none at
Or
all.
to even
Or,
beat that is
none.
they're on an estradiol pellet and they have a Mirena IUD, and the primary care or whoever placed it feels that progesterone is enough to cover the
progestin.
Right. It's
Yeah.
not even progesterone.
Yeah.
It's progestin, which is not good for you. That's adequate to cover and protect them, and it is not.
Because that's not systemic, correct? Is
Right.
that
Yeah, that just stays local. I mean, it's wild.
Yeah. And then, taking the estradiol now over to the men, a lot of primary care doctors don't understand the importance of estrogen in men. And that's something that I see when, initially we test for that in the beginning with men, but after that we really don't.
Well, we used to, and
Yeah.
we don't anymore. And I think that's what, like, it's fine if you want to test it, I think, but it can cause so much confusion. And that's why I recommend, and we've, it was recommended to us to just not check estradiol in men because, while, I do it personally, because I get curious and I like to see where things are at. But I mean, a lot of guys, we know that their estradiol is going to be high if they're on testosterone. And so
But that's what we want.
That's what we want. But guys will see that high number. Then they'll get on the message board and they'll get on Google. And then all of a sudden they think that they're going to get gyno, or they think that they're going to get over emotional, or going to think that they have all these like high estrogen symptoms that don't exist. And it just causes all kinds of confusion.
Well, and I think the important thing is I don't want to waste people's money. And drawing an estradiol on a male isn't going to change my testosterone doses. It's not going to change how I treat the person. So why would I charge them more money for a lab that doesn't really matter to me?
Yep, exactly.
Well, in all reality, men benefit from that, if not more than even their testosterone. And we have to overcome that as well. Like men don't understand that.
Well, half the benefits of testosterone come from estradiol. And we say that all the time. It is a prohormone. It metabolizes to DHT and estradiol. And so half the benefits are DHT and half the benefits are estradiol. And so going back to the number that you like to see for women, that's true for men. Like men also should be in that same therapeutic window that women are for their estradiol levels to get those same benefits, cardiovascular and bone density and neurologically and all that kind of stuff.
Okay, so I know we talked about like not necessarily needing to test for estradiol in men because it's not going to change the way that you treat them. So maybe we can kind of even talk about that a little bit in regards to antibodies for.
Yes, I'm glad you brought that up because I see that all the time. And we get that question a lot from people too, because especially when people come from, a lot of people have seen like these functional providers and then they come to us and it's like in the functional world, they over test for everything and they want to see 8 pages of lab work. And one of the things is thyroid antibodies is really popular to test for. And so just like Lisa said earlier with estradiol, like it doesn't change the treatment, just like estradiol doesn't change our treatment with testosterone, like the thyroid antibodies don't change our treatment for thyroid. We're still going to optimize T3. So like if someone comes in and they have a high TSH, I think it's like 90% of people that are hypothyroid have Hashimoto's anyways or something like that. So you can reasonably assume that they do have Hashimoto's. And then if you want to check it again on follow-up labs and kind of confirm if you want to look at antibodies, but again, it doesn't change the treatment. We still optimize T3. We don't treat antibodies. And it's just one of those things that, I don't know, I think it costs like $50 or $60. And so it's just one of those unnecessary charges.
And if we need to, I mean, we can, just like you said, we can throw that in on the follow-up if we're worried about it or you have any concern.
The other thing that I see coming in a lot is testing for people who have a genetic abnormality for folate. So they're wanting to get that test done, which is pretty expensive. But it's really not necessary. If you just take a methylated folate, you don't need to worry about whether you have that genetic abnormality or not. And why not just take the form of folate that is most absorbable instead of spending the money on a lab test to tell you whether you have it or don't have it.
That's a good point. Kind of the same thing we do with like vitamin D, right? We stopped testing for vitamin D3 because pretty much everyone's deficient.
Everyone's
If you're not taking it, you need
So
it.
just take a vitamin D supplement.
Yeah, and interestingly, I have some patients still to this day who only take it in the winter, but it's important to know in North Idaho, everyone's deficient year round. So just take it every day.
Just take it. Yeah. It's so cheap. Just take it.
So I know there's a lot of other like labs that we're looking at initially when we get patients in, but those are kind of the ones that we get a lot of confusion in and a lot of like back and forth, especially with general practitioners and stuff. So I think we really covered and kind of hopefully summed up why we do things a certain way, and maybe even like going forward can help answer any questions with their general providers in the future. So like always, please like, comment, subscribe, and thank you for joining us. We will see you next time.